Okay. Good morning, Mark. It's a great pleasure to have you. We feel that you are in the same room, although we have thousands of miles distance from Marseille to Athens. It's a great pleasure to have you in this roundtable discussion, which is just for the difficult to treat patients with the development of the new direct-acting antivirals. And we have slightly changed the program, so with Professor Koskinas and Professor Akriviadis, who are co-chairing this session, we are going to have you first speaking on your topic, which is the difficult to treat patients who have been previously in treatment with first generation direct-acting antivirals. And then we are going to have the discussion live, and you can answer all the questions. So your local time is around 10:30 in Marseille. Am I right or not?
Yes, you're right.
Well,
and thank you very much. Thank you very much for the kind introduction, and it's really a pleasure for me to participate to this great lecture. And I'm very disappointed not to be able to be with you in Athens. So my task this morning will be to discuss the treatment of cirrhotic patients and patients who are failure to first-generation protease inhibitors. This is my disclosure slides, and as you all know, since the last year, 7 new DAs have been launched for the treatment of Hep C. If we look at the different class of this molecule, there is 4 classes, namely the protease inhibitors, the NS5B, either nuke or non-nuke, and the NS5A inhibitors. So 3 classes and 4 with the 2 NS5B classes. And the new challenge with this new toolbox is that we are making different combinations according to mainly 3 things, which is genotype, subtype, and the cirrhosis. So currently we have studied different combinations either with a nuke and an NS5A inhibitors with 3 different potent antiviral DA but with low barrier of resistance as the AbbVie combinations, who associated the protease inhibitors, NS5A inhibitors, and non-nuke NS5B inhibitors, and also other regimen studies, protease inhibitors plus nuke. So currently, we have in 2014 all these combinations that have been launched for all genotype. And I would like to go through each combinations for each genotype in cirrhotic patients. However, despite the fact that all these drugs have been launched, only very few countries could have the availability of getting all these drugs together. And clearly in Europe, France and Germany were the 2 countries in which those drugs were most available and in which a lot of studies have been done. If we focus on genotype 1 cirrhotic patients, I would like to go through the different results with different regimens. And the first of all will be sofosbuvir plus PEG and RIBA. If we look to the clinical data, there was only data on naive patients in cirrhotic, showing that in cirrhotic patients, the SVR rate among genotype 1b patients was only 67%, however, look to the small number of patients. And we have no data from treatment-experienced patients, and all these data are currently coming from real-life data, and especially the 2 US cohorts, Target and Trio cohort. Among these 2 cohorts, more than 800 patients have been treated with these combinations of sofosbuvir, PEG, and RIBA. These cohorts were quite heterogeneous, with about between 30 and 50% of the patients who were cirrhotic, and a lot, around 50%, were treatment failure. Sorry. If we look to the result of this combination SOF, PEG, and RIBA in cirrhotic patients, you can see that the results in real life are good in naive patients, but are quite disappointing in treatment-experienced patients with only 65% SVR. In the target cohort, the results are on the same line, with only 70% of response in cirrhotic patients. So clearly we can say that according to the other regimens that we have, we can maybe withdraw interferon from our regimens even in cirrhotic patients. If we look now at the second combinations that have been widely studied outside clinical trial, cimeprevir and sofosbuvir, we have to keep in mind that the only clinical trial that we've got a result came from the COSMOS trial. In the COSMOS trial, in which some patients were null responder and advanced fibrosis or cirrhotic, 87 patients, the SVR rate is high, overall 96%, without any effect of the additions of ribavirin on the top of this regimen. However, there was a concern about the role of the subtype and the role of the Q80K mutation, because in the earlier study with sofosbuvir and with cimeprevir and PEG and riba, there was a disappointing result in genotype 1A patients who harbor the Q80K mutations. However, even when we move to DA combinations without interferon, like these associations of cimeprevir and sofosbuvir, in this case, overall, there appears to be no implications of the Q80K mutations on SVR rate. Recently, new communications have been done by a US team on the largest population in which Q80K mutations have been assessed. And clearly you can see that, again, with this combination sofosbuvir and cimeprevir, there was no impact of the Q80K mutations on SVR rate. In real-life study in the US, more than 1,000 patients have been treated with these combinations. And again, if you look at the result among the cirrhotic patients, in treatment-naive, 85% SVR, in treatment-experienced, 80% SVR. So very impressive result, even in PEG and riba failure, who is 87%. The same result is observed in the target cohort, in which the SVR rate with this regimen in cirrhotic patients is 87% in genotype 1 cirrhotic patients. And even in those with most advanced decompensated liver disease, we have a 75 SVR rate, which is quite impressive. Again, keep in mind that there is still a little difference between genotype 1A and 1B, genotype 1B doing better than genotype 1A. And again, in real life, there is no need for ribavirin. As you can see on this slide, the SVR rate is comparable whether you are using ribavirin or not in this setting, even in cirrhotic patients. As the safety issue are very good with these combinations, and as you can see on this slide, there was very few patients who exhibit serious adverse events, around 5% if you take both combinations of soft-sim or soft-sim plus riba. In these two cohorts, most of the patients have been treated for 12 weeks. In the post-transplant setting, the results are exactly the same, and even in cirrhotic patients, the SVR rate is very good with the combinations of sofosbuvir plus cimeprevir. However, the FDA label has been updated with these combinations, and interestingly, despite the fact that all the data are coming from mostly patients treated for 12 weeks, the recommendations from the FDA is for cirrhotic patients to use these combinations for 24 weeks without ribavirin, based on the fact that when they review all the data, there was no relapse by using these 24 weeks. However, we may have to deal with the cost and with the safety issue, and therefore in real practice, it's true that the 12 weeks regimen is the one which is preferred by most of the people worldwide. If we move to SOF and DACLA, There is currently no data regarding the use of soft DACLA with or without ribavirin outside in cirrhotic patients. We have data on the non-cirrhotic patients showing that the SVR rate is very high, and now we are currently treating patients with these combinations, soft and daclatazvir, for 12 or 24 weeks. And the result will be presented either by the English teams and the French teams and the German teams at the next EASL meeting. And I can share with you the fact that these results are good, and this is also a valuable option for genotype 1 patients, cirrhotic patients. If we move now to the fourth combinations, the combinations of sofosbuvir, ledipasvir, with or without ribavirins, the Harvoni fixed dose combinations. We initially have the phase 3 result coming from the ION2 study, showing that the SVR rate was in cirrhotic patients a little bit better if you treat your patients for 24 weeks compared to 12 weeks. And again, there was no evidence that ribavirins had anything in this small study. However, keep in mind that the number of patients here were very small, and therefore these recommendations of treating the cirrhotic patients for 24 weeks was based on this number of patients, and therefore it's a little bit, it's maybe not the good recommendations. And when we conduct a post-hoc analysis of all cirrhotic patients, compensated cirrhotic patients treated with sofosbuvir ledipasvir, it was in total 513 patients. You can see on the left part of the slide that the number in each arm was quite large, and we were able to look at the SVR rate according to these various regimens. Harvoni without ribavirin, with ribavirin for 12 weeks, and Harvoni for 24 weeks, with ribavirins for 24 weeks. And overall, the results are here, and you can see that there is no significant difference in terms of SVR, whether you are treated for 12 or 24 weeks. If we go a little bit deeper in this data, you can see that in the treatment-naive cirrhotic patients, there is really no difference whether you are treated for 12 weeks with Harvoni without ribavirin, or whether you add ribavirin for 12 weeks, or you extend durations of treatment to 24 weeks. So therefore, in treatment-naive cirrhotic patients, no difference, and Harvoni for 12 weeks is enough in order to achieve SVR. In treatment-experienced patients, the results are a little bit more confusing. And again, if you look at the SVR rate for those treated with Harvoni for 12 weeks, is only 90%. If you had ribavirin or extend the durations of treatments to 24 weeks, you are going to reach an SVR rate between 96 to 100%. So clearly here there is a trend for a better response if you had ribavirins for 12 weeks or if you extend durations for 24 weeks. There was no difference regarding genotype subtype 1A and 1B, and no other difference was found, except the fact that if you have low platelet level and advanced portal hypertension, again, you have the advantage of adding ribavirin for 12 weeks or extending durations to 24 weeks. And again, in this setting, 12 weeks of Harvoni alone is not enough. If we move now to the last regimens, the 3-day AbbVie combinations, here there is the combinations treatments should be given for 12 weeks, except in genotype 1A, prior null responder, in which clearly there is a difference of SVR if you are treated patients 24 weeks or 12 weeks. And in genotype 1B, there is no need for 24 weeks regimen, but for genotype 1A, there is the need of extending treatment durations only for those who had a prior null response. And that was confirmed statistically by the post-hoc analysis presented by Everson at the last AASLD meeting. If we move now to genotype 2 patients, everything is easy, even in cirrhotic. Here I put on this slide all the trial on sofosbuvir, ribavirin in genotype 2 patients. And as you can see, in naive patients, the SVR rates among cirrhotic in green are on the same line that in non-cirrhotic patients. The only bad response is those treated with PEG and RIBA, but when you move with SOF and RIBA, it's fine. In treatment-experienced patients, the results are on the same line, except the fact that in the fusion study, we see a trend of a better response if you extend durations therapy from 12 to 16 weeks. However, interestingly, in the Valence study, in which patients were treated for 12 weeks, genotype 2 patients, the SVR rate was 88. So that's only due to the number of patients. But clearly, in this setting, if you look again into real-life data from the target and the trio, in which 800 patients were treated with this regimen for genotype 2, there is a very good SVR rate, more than 90% in non-cirrhotic patients, but in cirrhotic patients, the SVR rate is 79, 83. So therefore, in this setting, in cirrhotic G2 patients, we maybe have the interest to extend the durations of SOF and RIBA up to 16 or 24 weeks. But currently, we have no data to present. The same result were found in the target cohort, in which in cirrhotic, the SVR rate was 88% for 12 weeks, SOF and RIBA. For genotype 3, that is maybe where the problem is still there. If you look at the result of cirrhotic patients, genotype 3 cirrhotic patients, you can see that clearly in naive patients, the results are good with SOF and RIBA for 24 weeks, or Arvoni plus RIBA for 12 weeks. Little bit disappointing with sofosbuvir, daclitazivir for 12 weeks. But in treatment-experienced cirrhotic genotype 3 patients, clearly there is a gap, and there is a need for an improvement of SVR in this population with maybe other regimens. So either SOF plus DAC for 24 weeks or the additions of ribavirins might be an option, or either the extensions of the Arvoni regimens plus ribavirin to 24 weeks might be also an option, or the other options may become with other compounds, and I will show you that later on. For genotype 4 patients, here is the result with SOF and RIBA regimens obtained in cirrhotic patients, here either in the US study or in the Egyptian study, and as you can see, the SVR rate is quite impressive even in cirrhotic patients. However, the best result is currently obtained by the SOF lady, the Arvoni regimens 12 weeks, in which in cirrhotic the SVR rate was high. But however, keep in mind that the number of patients treated, the number of cirrhotic patients treated is very low, and it's very difficult to draw any definitive conclusions. Another regimen which is very impressive in this stage is the 2D from AbbVie, the paritaprevir plus ambistazvir, the VKIRAX regimens plus ribavirin for 12 weeks. And again, either in naive or in treatment-experienced patients, the SVR rate is huge, 100%. However, there was no cirrhotic patients included into this study. So currently, no data on cirrhotic. For genotype 5 and 6, everything is simple. There is no data. The only data is coming from the Neutrino study, in which patients were treated with SOF, PEG, and RIBA, 100%, but only 7 patients. And for genotype 6, we have this nice study presented by Ed Gann, showing that ledipasvir sofosbuvir for 12 weeks was able to achieve an SVR in 96% of the patients. However, there was only 2 cirrhotic patients, so it's very difficult to have any definitive conclusions for this genotype. Now let's move to PI failure. So we have data now on PI failure with all these regimens. If we are using sofosbuvir, PEG, and RIBA in PI failure, in the trio cohort, the SVR rate is 73%, which is not bad, but clearly suboptimal. If we are using SOF and SIN in these patients who have failed to boceprevir and telaprevir, they were able in the trio cohort to reach 86% SVR. Here with a mix of patients with cirrhosis and without cirrhosis. So the only clear result we've got for cirrhotic patients came from the target cohort, in which those failure to boceprevir and telaprevir were treated with sofosbuvir, cimeprevir for 12 weeks, and they were able to achieve 79% of SVR in cirrhotic patients. Not bad, interesting in terms of virology, because despite the fact that these patients may have harbored some NF3 mutations, they have been responded to SOF and SIM. Now, if we move to SOF and DAC, we have a very nice result coming from the Sulkowski study, but again, there was no cirrhotic patients included, and in this study, with 24 weeks of this regimen, SOF and DAC, they were able to achieve an SVR in all patients except one, and there was no benefit for ribavirin. This arm was with ribavirin, and this one without ribavirin. So clearly, there is no influence of ribavirin on this setting. If we move now to the combinations of SOF and ledipasvir in failure to PI, again, in the ION2 study, there was result about cirrhotic patients, but look again, the result, they are very small. And again, based on this data with very small number of patients, the recommendation of the FDA and EMA was to propose a 24-week treatment regimen for these patients with ledipasvir and sofosbuvir. However, we have conducted, in cirrhotic PI failure, we have data coming from the target cohort, and again, this 79% SVR rate with SOF and SIM, and we have conducted in France studies in 155 cirrhotic G1 patients who were failure to boceprevir and telaprevir, and we randomized patients in two arms. One arm of 12 weeks of ledipasvir sofosbuvir plus ribavirin, and one arm of 24 weeks of ledipasvir sofosbuvir. We did not include in this study a arm of ledipasvir sofosbuvir without ribavirins for 12 weeks, because at the time we designed the study, the only relapsers were on this group. So as all these patients already exhibit multiple treatments and were failure on multiple treatments on PEG and RIBA, and therefore failure on triple regimens, we want really to maximize the SVR rate. And so these patients were not very well compensated cirrhotic. 26% of them has esophageal varices. They were all child pukes A, very few were child pukes B, and 13% had an albumin level below 35. They were all mostly genotype 1A, high viral load, and they were mostly have been treated with telaprevir than boceprevir, and some of them were also have been treated with valdaprevir and azunaprevir. 73% of them had NS3, NS4 mutations at baseline in ultra-deep sequencing, and part of them were part of the QPIC. And clearly the results are here, and they are completely comparable. There was no difference between 12 weeks of ledipasvir sofosbuvir plus ribavirin compared to 24 weeks of Harvoni ledipasvir plus sofosbuvir. All relapsers were male. The relapse was not particularly linked to the liver severity. They had all esophageal, they are all high viral load, and there was no link also with baseline NS5A rave. 3 of them had no baseline NS3 rave, and 2 of them had this NS5A mutation at baseline. So clearly there is no clear factor that could be associated with relapse. And again, if you look those patients with esophageal varices, the SVR rate among this population is comparable and not significantly different than those without portal hypertension. There is, again, no influence of NS5A rave at baseline on SVR. 16% of our patients exhibit this mutation on baseline, but despite that, they achieve 92% SVR, and the 84 patients who did not have these mutations at 88% SVR, no difference. And obviously, as attended, the NS3, NS4 rave have no influence of SVR rate. In terms of safety, both regimens were very well tolerated, but contrary to what we expect, there was a little more side effect in those patients treated for 24 weeks compared to those treated with 12 weeks. And the impact of the use of ribavirin in this setting was quite moderate because there was very few episodes of anemia, and there was only one patient who needed to have a transfusion and therefore had a severe adverse events due to the anemia in these 66 patients. So a very well safety issue. What will be the future for all these patients? We will have some data coming in the next months about the genotype 3 patients, and especially those cirrhotic patients, genotype 3, who are failure to treatment, who are patients who are difficult to treat. Clearly, with the new combinations of the GS5816, the new NS5A inhibitors, we really can expect to achieve in this regimen sofosbuvir plus GS5816 an SVR rate over 90%, which is a very encouraging result. With the new protease inhibitors from Merck, the grazoprevir, the second generation protease inhibitor, which is multigenotypic, as combined with elbasvir, which is an NS5A inhibitors, the results are also huge. And as you can see in the cirrhosis study, there was really no difference in terms of response between cirrhotic patients and non-cirrhotic patients. Moreover, if you combine these associations, grazoprevir plus elbasvir plus sofosbuvir in genotype 1 patients, in this small study, they were able to reduce the durations of treatment down to 8 weeks and getting still an SVR over 90%. So again, if we combine all these molecules, all these very potent molecules, we can maybe reduce the durations of treatments even in cirrhotic patients down to 8 weeks. In conclusions, I will say that with the current available regimens, most cirrhotic patients can achieve an SVR in 12 weeks with or without ribavirin. Genotype 3 treatment experienced cirrhotic patients remain a problem. New DAs such as GS5816 or longer durations of these combinations with or without ribavirins may resolve this issue, and the cost of the drugs and access to treatments remain the major problem in most of the country. I will thank you for your attention.
Thank you very much, Mark, for this very detailed account of what we have in hand and what we are looking for the future forward. I think that people here may have a number of questions, and I will like, in addition to the comments that may be raised from Professor Akriviadis and myself, first to ask the audience for their comments and questions. Ποιος θα ήθελε να λάβει το λόγο, να ρωτήσει ή να κάνει κάποιο σχόλιο? Παρακαλώ, δώστε το μικρόφωνο. So this is Dr. Papatheodoridis who would like to raise a question and ask you.
Hello, good morning, Professor Bourliere. Thank you for this very nice presentation. So my question is that, as you already presented, we have seen clinical practice data in which cirrhotic patients show to have SVR rates lower to the SVR rates we have seen from the trials. So do you think it is something different in clinical practice, or perhaps it's a different type of cirrhotic patients? Perhaps decompensated, when in clinical practice they say cirrhosis, perhaps decompensated cirrhotics were included as well, and we know even from the trials that the compensated cirrhotic patients have lower SVR compared to compensated cases. So do you think this is the case for the difference?
Yes, thank you, George, for these questions. But I think that our feeling is really that when we are moving to real life, the results are not so different that we have in clinical trial. And if I look in the patients that we have treated outside clinical trial this year, and we have treated more than 285 patients, and they were mostly advanced fibrosis or cirrhotic patients because it was the only patients that we were allowed to treat. The ASVR rate is between 80 and 90%, or 90% if you, depending on which genotypes you are looking at. And the worst result we have got in real-life study was really with SOF and RIBA, and especially in genotype 3 patients. But if I look at the result that we had currently with either SOF and SIM, SOF and DAC, Harvoni regimens in the cirrhotic patients, the results are still very good. There is some issue regarding the adherence to treatments, which I think it's still very important, because even if everything seems to be very simple, given 1 or 2 pills a day, it's not complicated when we are coming from the old time of Telaprevir and Boceprevir with these 16 or 18 pills regimens a day. But we have seen some very funny things about patients not taking their drug, despite the fact that the price of the drug is the price of an iPhone 6, and so it's very expensive, and we explain that to the patient. So despite that, I think this is one of the issues. But the interesting thing was that, contrary to what we observed before with Telaprevir and Boceprevir, our feeling is really that when we are moving with all these combinations, the results are not so disappointing. When you look at the results between Target and Trio, there is clearly a trend of a small difference between Target and Trio, with an advantage for Target compared to Trio. And maybe this is linked to the way the patients are followed and the way the patients are, I would say, helped during the treatments. There is also the issue of the drug-drug interactions that we need to take account. But globally, I will say that for the first time, I feel there is fewer difference between clinical trial and real-life data.
Thank you. I completely agree. Thank you very much.
Professor Bourliere, this is Dr. Akriviadis speaking from the panel. From the podium. It is not perhaps a time to talk about a la carte treatment, but in difficult to treat cirrhotic patients who were previously exposed to various modalities, treatment modalities. You think that it is reasonable to start with a triple regimen including ribavirin, or you would think that 6 months with a safer quote-unquote medication treatment would be the best solution? What would be your option in difficult to treat, particularly decompensated cirrhotic patients?
Well, my option in the cirrhotic decompensated patients will be right to now, due to the data that we have and the experience that we have, is to try to go for if I have Harvoni, I will go for Harvoni plus ribavirin, and I will begin it and say I'm going to go for 12 weeks. If I have any problem with ribavirin during the course of my treatments, I could maybe stop ribavirins and try to go for longer durations. We had also the same experience with SOF and DAC. And SOF and DAC, so the unknown questions actually is that we have treated most of the SOF and DAC patients without ribavirin and for 24 weeks, because we were based on the first data, and as these patients are more difficult to, we really want to achieve an SVR, we were going for longer durations. But maybe this is wrong, and maybe that 12 weeks will be enough. So I am waiting for the ILI-1 study to see part of the result among the most advanced patients, but I am not sure I will get the response, because I think that most of the response will come from real life. But in the real life data that we have treated in France and Germany with SOF and DAC, unfortunately, it was 24 weeks. So that's what we are currently doing. I think we have all this data coming from FLAME, and I think that Dr. Konongitas will present the data of STEF FLAME. And clearly in the FLAME data, there is no difference of extending the duration of treatment to 24 weeks when you add ribavirin. So the interesting finding that we found even in the serious study was that initially we thought that we will have a lot of side effects with the ribavirin in these patients. But by the end, if you are dealing with this patient, the number of safety issues due to ribavirin is much more lower than what we used to have before with PEG and riba. So this is, again, a completely new era in the treatment.
If I may ask one more question. In our previous session, there was we all agreed that there are no data why cirrhotics do not respond. We don't know, we don't understand the mechanisms of difficulty in response of cirrhotic patients. Based on your experience and the data you are collecting with so many large number of patients, you have any data on the mechanisms of difficulty in response of these patients, why they don't respond?
I think there is not a single explanation for that. I think that maybe have multiple explanations. One of them could be that when you have portal hypertension, you modify the blood flow, your liver blood flow, and maybe that could have an influence on the intake and on the metabolites of the drugs. And there is clearly data showing that, for example, with Cimeprevir, there is modifications of the metabolites of the drugs with more advanced cirrhotic. However, but there is no clear-cut explanations for that. And interestingly also, if we only look to the pharmacological data, for example, the combinations of soft SIM should not be used in child C patients, but as we have seen into the real-life data, some of those patients have been treated with these kind of regimens without having any real deleterious side effects. So I think always that there is some difference and discrepancy between what we could find in some non-HIV infected cirrhotic looking just at the metabolite of the drugs and what's when you move to clinical real-life data in which the result might be a little bit different.
Any other questions? Yeah? Dr. Deutsch.
Hello, Professor Bourliere. Thank you very much. My question is related to George's question and the others. Is it possible in the real-life studies, do you have any data if comorbidities like diabetes mellitus or cryoglobulinemia, do they influence the results, the SVR rate? People in real life have other comorbidities. Maybe this is important.
That, to my knowledge, there is no data showing any difference in terms of response according to these comorbidities. However, this is something that we need to study, and clearly in the Ηπατέρ cohort, in which we have quite a large number of patients with comorbidity, we are going to look at that. But the problem is that due to the high rate of SVR, it's very difficult to find any evidence, to find any easy difference, because when you are with a such high SVR rate, to be able to demonstrate that a single comorbidities, for example, such as diabetes, is able to influence SVR, needs to have a very large populations to assess that. So I think that currently we are going to present all our data at EASL, and I think it will be very interesting that, for example, from the French, the German, the UK cohort, to put together all our cohort in order to maximize the number of patients treated and to look at this problem. Because if we are just looking with our quite large but not enough large cohort, we will be unable to draw any conclusions. So this is still unanswered questions.
Dr. Manolokopoulos.
Thank you very much, Professor Bourliere, for your excellent talk. I'd like to ask you, what's your practice for the small number of the patients who break through or relapsed after interferon-free regimen?
So currently, for the few patients who relapse, because they were not breakthrough, they were relapse. The only breakthrough that we have was the patients that we are treated with soft Riba, or those treated with Cimeprevir, PEG, and Riba. Otherwise, if we are looking at the patients treated with soft DAC, soft SIM, Harvoni, or 3-day from AbbVie, they were relapser but not breakthrough currently. So currently, if a patient failed to, for example, soft and SIM, relapse after soft and SIM, everybody, they will be treated with soft and DAC or Harvoni plus Ribavirin. If they fail to to Harvoni, or if they relapse to Harvoni, or if they relapse to soft and DAC, soft SIM could be an option. And currently, we are trying to set up a clinical trial in order to try to propose, I will say, triple combinations with more advanced drugs that are coming. So clearly, a regimen like, for example, sofosbuvir, grazoprevir, elbasvir will be of interest to study in such combinations. So that's the next step and the next future. But it's going to concern a quite limited number of patients.
I think that we have, there are some, it has been questioned whether we can take the opportunity to have Mark a little more of this. I would like maybe 5 minutes more, Mr. President, Dr. Koskinas. Okay, that's all right? Agreed, agreed. Now you have a great experience on this, and that's my own attitude looking at the literature all these years with the development of the direct-acting antivirals. I get the information you are accumulating after the other. The best polymerase inhibitor is the nucleotide inhibitor. Which is the best NS5A inhibitor? I don't really know. There is maybe some conflict of data. That maybe it is 5816, maybe, I don't know. It is probably ledipasvir. I don't know which is the best, but these are the candidates for being excellent NS5A. And I think that if you go also to the protease first generation or protease inhibitors, then you have an emerging one which has not come into the development, which is the Mar product 5172. I wonder, I'm not, romantic, whether one could say different companies, different pipelines, if one could combine all the best, the NS5, the protease inhibitor, the best NS5A, and the best polymerase inhibitor, would be 100% efficacy for all patients. This is something looking at the future. No companies could go ahead developing drugs from other pipelines. But I wanted to ask Dr. Bourliere, what would he think as a scientist and investigator and the clinical worker?
No, I totally agree, Stefano, and I think that that's the main problem, because the company here are very reluctant to release the drug for us in order to set up studies with such combinations. And even at the earliest time when we tried to combine and to do study with soft SIM and DAC, for example, which was the first one, it was very difficult to have the release of the drug for this. And as the states were unable to pay for that, we were unable to set up the study. And we tried to set up a study like that. And in fact, it has been done by company, and there is a currently ongoing study with Janssen, in which they are combining sofosbuvir, daclofenavir, and cimeprevir, for example. But clearly, what we want to do, and as scientists, we would like to have the access to all these drugs in order to do what you propose, in order to try to select the best in class and to try to combine it in order to reach a kind of perfectovir that could be the ideal drugs to solve all the problem. In terms of the NS5A inhibitors, the current available NS5A inhibitors, it is true that the GS5816 is very promising. It's very promising because it seems to fulfill the gap for genotype 3 patients. However, we have to be cautious because all this drug is now in phase 3, and we have to be sure that there is no safety issue. For the other 3 other molecules, and especially we have quite a large number of data on safety, which are very good, and therefore there is no major issue. I think that daclatasvir is maybe more pangenotypic or multigenotypic than ledipasvir. Ledipasvir is not working, for example, in genotype 2. It's working in genotype 3, genotype 1, genotype 4. It's working in genotype 6. In genotype 5, I think that will be some data that are going to be released at EASL on this special population, but it is a very small proportion. And for the third one, which is the orbitazvir from AbbVie, there was only study on genotype 1 and 4. But again, this drug might be interesting to study in combinations with the other, exactly as elbasvir, which is the MSD NS5A combination. So the huge problem is that it's difficult to have all these drugs at our disposal in order to conduct this clinical trial.
Well, thank you very much. I think this is a promising future approach. Thank you very much.